Welcome to Chapter 2, The Well-Being of the EMT. This is a particularly important chapter, one that really deserves a lot of attention and recognition. Over the past few years, we've started to learn a lot more about mental health issues with first responders and the effects that it has not only at work, but also on our home lives. When we discuss the well-being of the EMT, we're going to talk a lot about how we can take care of ourselves, which is kind of a different dynamic than what the other 38 chapters are about. The vast majority of this book and this curriculum, for that matter, discuss how we can take care of other people. But what we don't understand is that taking care of ourselves is just as important, arguably more important. If I'm not in the right frame of mind, if I'm not uh, aware of scene safety concerns, if I am not taking care of myself physically and emotionally in advance of a call, that does impact the quality of patient care that I'm able to provide. So really open up your minds and listen to what's said during this discussion and consider how it may affect you in your life. So to begin, let's talk a little bit about the importance of well-being. Um, we talk about being prepared, and every morning, more than likely, you're going to do a vehicle check. You're going to check the equipment bag on your ambulance. You're going to check all the compartments. You're going to make sure that your equipment is in working order, that everything is there, ready to go when you need it. But what else can we do to make sure that we're prepared? How do we prepare ourselves physically and emotionally? What happens when we show up to work hungover? We've all done it, or if you haven't, you will. I'm sure of it. It's something that maybe it's poor planning, maybe a bad decision was made the night before. But when we show up hungover, tired, or just generally sick, uh, that really does impact our performance. It impacts how sharp we are, and it opens us up to the potential for further damage to ourselves and for mistakes to occur when dealing with our patients. We need to be sure that we're maintaining solid personal relationships. And when we talk about those, that's more than just relationships with a boyfriend or girlfriend, a husband or wife, mom or dad, brother, sister, or the people you work with. It's an entire web of individuals that are able to support us, that are willing to listen to us and be there for us. Those personal relationships allow us to open up and vent some of the inner stressors that we deal with on a regular basis. More than likely, a lot of the personal relationships that we're going to be able to utilize for getting rid of stress is going to be those at work, our coworkers. There are no other individuals in this world that truly understand what a first responder goes through except other first responders. We've even learned that we're going to talk a little bit later about critical incident stress management. And there are trained counselors that will come in and talk with us and try to help us through some tough times when we go on a difficult call. But what we've learned is that the people that are best suited to work with us, to talk to us, to listen to us, are other first responders. So rather than bringing in counselors to help firefighters, now we're just training firefighters to be counselors, and it's becoming a lot more apparent. There's these individuals, these groups are popping up all over the place, and we're finding that they are far more effective. So, what are some other things we can do? And I want you to think to yourself, what is it that you do to manage your stress to keep yourself healthy? Obviously, exercise is super important. We all know that. But sleep. Recent studies have shown that sleep is honestly probably the biggest contributor, not only to the heart disease that plagues the fire service, but also to our stress levels, to PTSD, and the rising suicide rates that we're beginning to see in first responders. We're busier than ever. Our call volumes are up. The demands on first responders are higher and higher. Consider the demands on law enforcement these days, and the fact that they're always on camera, they're always being recorded, and if they just simply say something or do something that is misinterpreted, there's a world of hurt that comes down. Uh, we're exhausted as first responders today, and we're not getting enough sleep. We're not getting enough sleep while we're at work if we're in the fire service, and we're not getting enough sleep while we're at home because we're up thinking about other things that go on with our job, family stressors, things like that. Diet is super important. If you are in class with me, I will talk to you substantially about diet and how to prepare yourself even for things like an exam. What you eat prior to an exam will impact your performance. How you eat on a regular basis, prior to shift, during shift, will affect your performance. Alcohol and caffeine intake. Now that's tough for me to say a whole lot because as I record this discussion, I'm sitting here drinking a cup of coffee and I have an entire pot waiting upstairs for me to continue to refill. Um, Speaking of sleep, I came home this morning after being up for about 25 and a half straight hours. Did not get a single minute of sleep. Was able to score about 2 hours of sleep when I got home. And then, of course, my 4-year-old wanted to wake me up and show me some great things, which, hey, I love that little boy to death and I'm happy to wake up for him. But even right now, as I sit here and I talk to you, I'm tired and I am trying to remedy that by drinking a lot of caffeine. Is it the right thing to do? No. Do I have much of a choice? I really don't. I have responsibilities, I have deadlines, and these are things that I have to get done. Limiting alcohol intake. Going out socially, assuming, of course, that you're over the age of 21, going out socially and having a drink, maybe a glass of wine at dinner, those types of things. We see even that there's studies that say that that's good for us. A glass of wine may be heart healthy for us. But we also know that there's a growing trend among first responders that we don't go out just for a social drink here or there. We're going out, we're binge drinking, we're drinking on a regular basis, we're drinking alone. We're drinking because we're trying to medicate some of the stresses that we deal with. And what makes that incredibly difficult is that we don't always recognize that that's what's happening. We don't even recognize that we're stressed a lot of times. I've been on the job almost 13 years now, and I'm just now beginning to understand a little bit more about my personal behavior challenges, what I do, how I change when I'm stressed, how that affects my family, and what people from the outside see of me. It's not something that is easy to accept, and it's surely not something that's easy to change. And unfortunately, many of us choose to use alcohol to just kind of numb the effects rather than approach it head on. Regular visits with your physician, physicals, that's probably going to be part of an employment routine, but there's also, you're able to schedule your own appointments. Maybe you go and see a therapist on a routine basis, not because you're depressed, not because, there's a specific reason, but just for general wellness. And I want you guys to think about mental health no different than any other medical condition. If I were having crushing chest pain that radiates to my left arm and I've got shortness of breath and I'm pale and diaphoretic, I'm going to call 911 and I'm going to go to the hospital because I'm afraid I'm having a heart attack. And at the end of the day, the heart is an organ just like the brain is. And if the brain is having an issue from a mental health perspective, maybe I'm depressed, maybe it's exhaustion, maybe it's any number of things, then I need to be just as confident and just as proactive to take care of those issues as I would a heart attack, stomach pain, or any other ailment. So let's switch gears a little bit and talk about personal protection. What is it that we can do to protect ourselves? And again, remember that by protecting ourselves, we're also protecting our crew and we're protecting our patient and our bystanders. So standard precautions. Standard precautions is a general term that just means that we are going to take steps to make sure that we can protect ourselves. Maybe that means that we're isolating ourselves from blood or other body fluids. Maybe that means that we're protecting ourselves from unsafe situations. It's a general phrase that just says, hey, I need to watch out for me, make sure that I can do my job safely so that I can continue to care for others. One of the things that we're going to do in order to take those standard precautions is to do a good comprehensive scene size up. Now, when we look at our assessment algorithms, scene size up is the very first thing that's listed. It says scene size up and BSI, body substance isolation. We'll talk about that in a second. But with scene size up, it's not just something we do once at the very beginning and then move on. It is continual. It is ongoing. It never stops. From the time that the tones drop to the time that you transfer care at the hospital, you will continue to size up the scene because anything can change, anything at all. Oh yeah, by the way, if you haven't figured it out at all, if you see little notes in here, arrows or something that's highlighted, that's probably because you'll see that pop up on a quiz or an exam or something like that. So the Occupational Safety and Health Administration has issued guidelines about precautions, and it talks about things like hearing protection. It talks about wearing gloves. It talks about exposure controls, all sorts of things. And you're going to want to review your local protocols through your EMS system and also any department policies that you may have. And all of those should reflect state and federal laws. So there's some examples of personal protective equipment. Different types of gloves, masks that protect us from things like tuberculosis, glasses that will shield our eyes. Remember that anywhere that we have a mucous membrane or broken skin in our body opens us up to the potential for exposure. That means that if you have eczema on your elbow, I get eczema that flares up seasonally. Every fall, skin dries out, and I've got an eczema issue. If I were to come in contact with blood, there's a good chance that because my skin is not fully intact there, that would be an exposure issue. So I personally need to consider wearing long sleeves every day when I go to work. Or maybe I wrap my elbows, do something like that. So we need to be aware of not just the obvious things, the eyes, the nose, or the mouth, but we need to be aware of nail beds. We need to be aware of cuts or scrapes that we may have on our skin. We need to cover anything where something could potentially break the skin and contaminate us. So protective gloves is important. I think that probably goes without saying. It's common sense. And there are even special tactics that you use to change your gloves, and we'll discuss those in class. And here's some great pictures that describe how to remove your gloves. I'm confident that all of you guys will be able to figure that out. Keep in mind that washing your hands is the best option. Soap and warm water is the best way to decontaminate and get rid of germs. If you don't have access to soap and water right away, an alcohol-based cleaner is at least a good temporary solution, but you should always follow up with a good scrubbing at the sink. Eye and face protection. There are lots of different things available: glasses, face shields, masks. Be sure that you're wearing the appropriate PPE for the situation. We do not need to go overboard. We're not going to gown up all the time for every patient that we come in contact with. Wearing excessive PPE can not only take additional time, but it's also going to potentially make the patient or bystanders a little on edge or uneasy. Consider if you go on an airplane and you see a bunch of people wearing masks. Well, to me, that says that either they know something I don't know about the other people on the plane, or maybe that they're sick and they're just trying to keep those airborne particles contained. Either way, it makes me feel just a little less comfortable. If there's an obvious threat and I need to protect myself, my partner, my patient, that's fine. But going overboard preemptively is not necessarily appropriate. There we go. And yeah, that mask to me just reminds me of a duckbill. So I put a picture of a duck. I hope you enjoy it. So some more masks, N95 HEPA masks. Those are designed specifically to filter the air coming in. Those things are appropriate for things like tuberculosis. Here's a great example of not only wearing gloves, but also a complete face shield. When we're suctioning, and especially when we're dealing with patients with vomit, there's a potential for that to spray up on us. And that face shield and mask completely covers all of the mucous membranes. The gloves cover the nail beds, and this patient or this care provider is completely protected. So gowns are appropriate from time to time. If you are concerned that there's going to be a lot of splash of bodily fluids, a gown would certainly be the right way, or the right choice rather. However, consider this: if you're responding to a gunshot wound or a stabbing, and you arrive on scene and there's a ton of blood all over the place, that patient is time sensitive. They are critical. Are you going to take the time to stop, get a gown out, put the gown on? And it is time consuming, trust me. Or are you going to just make sure that you protect the mucous membranes, take care of the hands, and go from there? Your uniform can always be stripped off. washed. It could be thrown out if need be. And at the hospitals, you can always get a pair of temporary scrubs if your uniform does get contaminated until you can get it back to the station and wash it. My recommendation for PPE when it comes to childbirth. Obviously, I'm being a little facetious here, but I can tell you that from my experiences in assisting in the delivery of children, it is the messiest situation you could possibly be in. If you have time to put a gown on with childbirth, I probably would do it at that point. I also recommend booties, face protection, mouth protection, gloves, and just about everything else you can possibly imagine. Talking a little bit about different diseases of concern. So when we think about diseases of concern, AIDS always tends to be at the forefront of everybody's mind. In fact, AIDS is really not a risk to first responders at all. So long as we don't have blood-to-blood contact or we're not having inappropriate contact with our patients, we shouldn't be too concerned about AIDS. However, with hepatitis B and C, those are things that are a lot more prevalent to us. Hep C especially. Hep C can stay alive in dried blood outside the body for 7 to 10 days, meaning that a patient could bleed on a cushion in the ambulance, and if it doesn't get properly decontaminated, somebody that comes in contact with it next week would potentially be exposed to hepatitis C. There are some hepatitis B you can be vaccinated for. Hepatitis C, there are some vaccinations that are becoming available, and there are some treatments and some trials on different cures. So I think we'll see some changes with that coming down the pipes in the next couple of years. Tuberculosis is airborne. That's what makes it difficult. It's very easy for me to identify blood, vomit, or other bodily fluids and do my best to avoid it. But when something is airborne, I can't avoid the air. So with tuberculosis, we need to identify the potential signs or symptoms of a patient, coughing, blood when they cough, those types of things, and say, okay, this could be a potential airborne issue. I'm going to put a mask on myself, and I'm also going to put a mask on my patient. And keep in mind that if we're going to put a mask on our patient, if they're ill, a non-rebreather mask would be a great option. Not only does it provide the oxygen that they need, but it also prevents any contamination of the air. HIV and AIDS then, again, not really a big deal to us. We routinely have patients that will identify that they are HIV positive or that they have hepatitis C. It does not impact our treatments at all. We may take a few extra standard precautions, but we will treat and care for them just the same as we would anybody else. All right. I'm not going to play this video right now, but what we have seen is rather than AIDS, we're starting to see Ebola. A few years ago, we had an Ebola outbreak, and just within the last couple weeks, I received another bulletin that there is an Ebola outbreak in Africa. So we're going to be at a position where we have to start monitoring people who are coming in from outside the country. Where have they been? What are their signs and symptoms? And recognizing the potential risk for an Ebola spread. So there you go. People in the U.S. infected in 2014. It's 2019 as I record this right now. And again, it is again becoming an outbreak. So we have to keep an eye out for that. I'm not going to go through the rest of these. There are a lot of different conditions and diseases that we have to be aware of. And as they become prevalent, we typically receive bulletins or notices from the EMS department, from the county health department, or even from state and federal agencies. Influenza, just to go back and note that, flu shots are typically available through most employers and through the college for class. For class, it's going to be a requirement. You have to have your flu shot done in order to do your clinical time. I really recommend that you go ahead and get this done, even if it's not a requirement. No, you don't get sick from it, no matter what people have told you. It is a dead virus that is injected into your body just to develop the antibodies. All right. OSHA controls a lot of our workplace safety and exposure rules. We also have different protocols that will help to govern that as well. I want to keep on moving here. Ryan White Care Act. So this is an important thing to know. You'll probably see this referenced again. The Ryan White Care Act is legislation that was put in place in 1990. And what it means is that every department or employer shall appoint a exposure control individual, that if we become exposed, we are to report it to them right away. They are then obligated to follow up and determine whether or not the patient may potentially, based on a review of their medical history, have a communicable disease that we would have been exposed to. If so, they come back, they notify us. Essentially, they act as a liaison. And at that point, we can begin to seek some type of treatment, if need be, to prevent us actually contracting a disease of any sort. So Ryan White Care Act is really good. It allows us that opportunity to kind of identify if we were exposed, if we are at risk, and to get preemptive treatments. So yeah, 2 notification systems, one on a potential airborne disease. So if a patient goes into the hospital, they're in the hospital diagnosed with tuberculosis. That's not something we would have known during our patient contact. So the hospital would then notify the liaison. That liaison would then notify us. We'd be able to seek treatment. With the bloodborne or other infectious disease exposure, what happens there is that we identify that we were exposed to blood splattered up in a mucous membrane. It got onto a scratch or cut on our body, and as a result of that exposure, we want to go through and find out if there are any risks and whether or not we want to get treated. Respiratory standards, tuberculosis. This is all stuff in your book you guys can review or read over the slides. Nothing that I need to talk to you guys about, though. All right, emotion and stress. This is the meat and potatoes of this chapter. So emotion and stress. We talked a little bit about PTSD, and PTSD is often attributed to military professionals, especially over the last couple decades, where we have spent a lot of time engaged in war overseas. Our servicemen and women are coming back home. They have experienced some very traumatic events, and as a result, there are some long-lasting and oftentimes permanent scars, mental scars, that they have to deal with. And what we also know now is that first responders are also subjected to that. We see some different signs and symptoms from time to time. Oftentimes with us, it is a prolonged issue over many, many years. And as a result, sometimes it's difficult to recognize. So anyways, let's get into it, and we'll talk some more about that. You'll see that some of the upcoming content is a little bit different than your book. These are actually slides that I put together and copied in here so that we can talk about some specifics. Harold Schaperger is the president of the International Association of Firefighters. That is the national union that covers all professional firefighters in the United States and Canada. The IAFF has taken a very proactive stance on mental health and behavioral issues, and they're trying to work aggressively in order to try to get us the help that we need and make sure that we are able to live not only a good career but a long life afterward without being plagued by mental illness. And he says we need to do a better job of recognizing the signs and symptoms and providing the tools to help address it. Isn't that the truth? So what is stress? You know, maybe some of you are stressed taking the class. Maybe some of you get stressed when an exam is coming up. Maybe some of you are stressed because of deadlines at work. Any number of things. Stress can be caused not only by obvious outside influences such as those examples, but it could also be little things. Maybe I have 2 cats. I don't like cats. I'm sorry. If you're a cat lover, we can agree to disagree, but I don't love cats. My wife, unfortunately, does love cats, and if you're married, you know, happy wife equals a happy life. But those cats stress me out. I get angry every time I see the cats. Now, could be the cat's fault, or it could be that I'm displaying some mental health signs that I need to be aware of, where there's outside stressors that influence that. But I don't like the fact that the cats shed. I don't like the fact that they cough up hairballs. I don't like the fact that no matter how often you clean a litter box, you can still smell the litter box. These are all things that stress me out. There are things at work that cause stress. Maybe it's a personal relationship with somebody that is slightly soured. Maybe it is a training requirement that we believe to be overly burdensome or difficult. There's countless examples of where stress can come from. And all too often we focus on just these big ticket items, these big fires, or where we deal with death or a bad car accident, somebody that gets maimed. And in fact, there's a lot of subtle issues that can really lead up to a cumulative stress response within our professions as well. So the general adaptation syndrome, when we feel stressed, our body releases cortisol into the bloodstream, and it also responds with an adrenaline rush or an epi dump. And as a result, our heart rate goes up, our pupils dilate. It's that fight or flight response. We lose dexterity in our fingers, fine motor skills are lost, we lose short-term memory function. All of these things happen. And the best way to understand when this may kick in would be an obvious example. Let's say you're about ready to get into a fight. Somebody is presenting to you aggressively. They are indicating that they intend to do harm to you, and as a result, you become defensive, right? Your pupils dilate so that you can see everything that's going on. Your heart rate increases. You're able to either fight back or run, whichever one is appropriate, and your body is really amped up and ready to go. That is the beginning stages of the general adaptation syndrome. That is your alarm stage. And every time we encounter a stress, whether it be severe or minor, we have some level of the alarm stage that kicks in. Over a period of time, if we're not able to remove ourselves from the stress or mitigate the stress in one way or another, then we begin to adapt. And the resistance phase means that our body kind of just becomes accustomed to this constant stress, and we no longer feel stressed. So we don't realize that the stress is still impacting us. Our body adapts. Unfortunately, though, even though we feel like we've adapted and that maybe we beat the stress, the truth is the stress remains. There is still a subtle alarm response that is occurring in the background. Our heart rate and blood pressure may still be elevated, and we're doing physiologic harm to our body. Over a period of time, if we still don't mitigate that stress, if it doesn't go away, if we can't truly recover, then that constant adaptation, or so we think, that is plagued by the ongoing hypertension, tachycardia, and other physiologic responses, eventually our body gives up. It just gets exhausted. And at that point, we start to feel things like burnout, fatigue, and those things. So with the alarm stage, we're kind of in the moment. We know what's going on. Resistance stage, we feel like we've beat it, but in fact, we're irritable. We're not communicating well. Maybe our family or coworkers realize that there's some behavior changes that are alarming. And then the exhaustion phase. That's I quit. I give up. I don't want to do this anymore. I'm too tired to continue to fight it. Just whatever. And I'm sure we've all gotten to the whatever phase. And although sometimes it seems like we're just finally letting go and not letting it bother us, the fact is we're probably in that exhaustion phase, and it's bothering us a lot more than we know. So again, first stage is the alarm reaction. Second stage is resistance, or us trying to cope with it, where we think that we've adapted, we think that we've beat it, but in truth we haven't. And then the third stage is exhaustion, loss of ability to resist or adapt to the stressor. We want to avoid that at all costs. So how do we avoid stress? Well, first of all, we need to identify the types of stress, and then we need to be able to identify what works for us for stress prevention. So acute stress is something that's obvious. We respond to a pediatric cardiac arrest. We respond to a violent situation in which multiple people are injured. A bad fire in which somebody is burned or dies. These are all types of things that are big events. They're obvious. Holy cow, yeah, this should stress anybody out. And those are easy to identify. What isn't easy to identify are these small little cumulative things. And it doesn't necessarily have to be in response to calls. It could be maybe a handful of calls over a period of 10 years. Little calls here and there that cause you to. Let me give you this example. When I became a parent, calls affected me much differently as a father than they did prior to that. Now, as we're young and generally inexperienced, which the vast majority of students taking this class are going to fit that category, um, we still have a lot to learn. There's still a lot that we don't understand that poses a threat to us. We're bold, we're aggressive, and we generally don't fear a whole lot. And as a result of those things, sometimes we think that we're just kind of able to skip over horrific incidents. And I'll give you an example. Um, we responded a period of time ago, myself and a brand new firefighter EMT at the ripe old age of 19 years old. We responded to a pregnant patient having abdominal pain. We got there. She met us on the front porch, put her in the ambulance right away. She says she's having terrible cramping. And as we're getting her ready to sit her down on the cot, she says, "Oh my goodness, I think the baby just came out." Now, she was 17 weeks pregnant. We sat her down, removed the pants, and in fact, the fetus was right there, um, just within her sweatpants. And it was a stillbirth, meaning that the baby was deceased at that time. Now, this is incredibly traumatic, obviously for the mother who just lost their baby, but also for myself and for my partner at the time. As at the age of 19, this was something that was new to him. It was sad. It's easy to understand how that type of situation could really bother us. But as a father, for me, um, I became empathetic. I I know what it means to love a child as your own. I know how potentially um, traumatizing it would be to lose a child. So for me, it impacted me much, much differently. For him, yes, this was bad. He felt terrible. This is a horrible situation. And of course, there was an emotional response there. But for me, it was really, really a different experience. And that comes just based on life experiences and where we're at in our own individual lives. As a parent, when you deal with issues that involve children, it will mess with your head uh, entirely a million times worse than it did prior to parenthood. So, anyways, having small little things like that over the course of a career that kind of sit in the background. Not any one event was massive or just really memorable, but as you go and you respond to hundreds and even thousands of calls over the course of years, you can begin to cumulatively build up those stressors. And as those begin to happen, that's that general adaptation syndrome where we've hit that alarm stage on multiple occasions. We've hit that resistance stage, but we've never truly fully healed because we don't know how to heal. We're not talking about things appropriately. We're not caring for ourselves physically. We're not eating right. We're not exercising. Um, we're not opening up. And all of these things allow us to shield those stressors, but never to actually cure them. It's like constantly taking a medication that doesn't actually work. The underlying illness is constantly present. So with those, we're starting to see a lot of burnout. We're starting to see those fatigues, and with these individuals that are suffering this cumulative stress, we know that especially among firefighters and law enforcement now, the suicide rates are off the charts. Um, there's some studies out there that predict that nearly 50% of first responders have at minimum thought about suicide at one point in their career. 50%. If you look around the room and you think about all the people that will eventually be working in the fire or EMS or law enforcement fields or even in healthcare, um, and just think half of the people in the room around you right now will more than likely consider suicide at one point in their career. That's mind-boggling to me, and that's not acceptable. We have to be better. We have to be more proactive at caring for ourselves and caring for the people around us. That brotherhood, that sisterhood, that's real, and we really need to take advantage of that. PTSD then is a chemical disruption that they have begun to identify within the brain, and it's to the point that they can diagnose the PTSD, and in some instances, some states are even beginning to identify PTSD as work-related, and people are able to go off on disability because of PTSD. And this may be something. It's going to be a lot of times related to cumulative stresses, but it could be related to an acute stress also, where over time that acute stress just continues to haunt us, and it permanently scars us because we weren't able to heal ourselves appropriately. So PTSD, that post-traumatic stress disorder, change in the way we react or respond to a stress. And again, it may be a single incident or it may be multiple over the course of time. So there are so many things that we can do to identify the potential effects of stress and to not only just identify it in us, which is going to be extremely difficult, but more importantly, to identify it in others and know how we can begin to talk to them and address our concerns. And it could be things like a lack of appetite. Or for me, when I'm stressed, I eat more. I stress eat, and that's one of my biggest challenges with weight loss is trying to overcome stress and make appropriate decisions when it comes to diet. Lack of enthusiasm, lack of sex drive, and short of getting overly personal, I'll be the first to tell you that there was a period of time in my life where I was extremely stressed, and um, I wanted nothing to do with my wife. I lost my sex drive altogether. And at the time, as a male in his 20s, that should be a huge red flag. I don't know of any situation that occurs naturally where a 20-something-year-old male does not have some type of sex drive. So consider that when dealing with your significant others. If you see substantial changes, it may not necessarily be a strain in the relationship. There may be external stressors. And if we just assume that, oh, it's a relationship issue, they don't love me anymore, whatever the case may be, we may be missing a huge, huge clinical indication of some pretty significant stress impacts on our loved ones. And it's important that we begin to address those and be proactive. So, what are some other challenges that we present? As a firefighter, we often joke who do the cops call when they don't know what to do? The firefighters. And truly, that is some truth. We're at the end of the line. When people don't know what to do, when they need help, the default is to call the fire department. And that's just the truth. If a little old lady has a leaky toilet, she's going to call the fire department. We fix toilets. We help people when they fall and they can't get up. We've helped when animals are stuck. We really do whatever is asked of us. Along with those expectations comes a macho attitude. Well, look at me. I'm well trained. I'm very capable. I'm a big, tough firefighter. And we've tried to live up to that persona. And unfortunately, what that's done is that's caused a lot of harm. Being tough physically doesn't mean that we have to be tough mentally. We can be open, we can be susceptible to talking to others, we can be vulnerable. Those are all things that are okay. We have to change the culture. We have to accept the fact that mental health is something that people can't control on their own. Mental health is not something that has anything to do with somebody's ability to do the job. It is something that we all come across, something that we all have to deal with. And once we begin to accept it and work with each other to embrace it, we'll be much better off. So some other things, shift work. Shift work, a lot of that because of the sleeping schedules or the lack thereof. We found that if you don't get enough sleep every single night, you're starting to release more and more cortisol into your body, and that's doing some pretty substantial harm. Exposure to death is one of the more obvious ones. Failed rescues, anytime that we feel like we failed at our job, we were unable to do what we needed to do to save somebody's life, there's going to be an underlying sense of guilt that comes about as a result of that. And in all honesty, there may be some fault. We may be screwed up, and I can tell you that I've made mistakes, plenty of them. And I have to own those, I have to accept those, and I have to work to overcome them and make sure that it never happens again. But I also have to understand that, you know, I'm human. We're all human, and we have limitations in what we can do. So we can't be too hard on ourselves. Family versus department loyalty is the biggest challenge I think ever. I've seen, I can't tell you how many firefighters get divorced or go on the brink of divorce because it's tough to make those commitments. If and fortunately for me, I'm not on a department where I have to respond from home anymore. But earlier on in my career, that was absolutely the case. And I remember that my wife, at the time, was still my girlfriend. She was coming over to my house for a birthday dinner. It was her birthday. I was going to take her out to dinner. We had a nice date planned. And as she pulled up in front of the house, I was running out. I said, "Hi, hon. Happy birthday. Sorry. Gotta go. There's a fire." And thank God she's accepting and willing to just God bless her soul in general. She's such an amazing woman, and she's able to tolerate that. She's able to accept the demands of the job, and that it is a balancing act. But there are plenty of times where we have to say no to the job, and we have to take care of our families. We have to take care of ourselves, because if either the job suffers, then our family suffers, or if our family suffers, then the job is affected. They're completely linked. We cannot leave the firehouse. We cannot leave our ambulance company employer. We don't just leave and clock out and then forget about it. The things that we do while we're on shift live with us 24 hours a day, 7 days a week, 365 days a year. So it's super important that we find a way to balance, and super important that we recognize and respect the fact that both family and work are related. And if one suffers, so does the other. So as far as effects of stress, again, you can read through the list. It's different with everybody. And what I encourage you to do is go home, or if you're listening to this from home, go and talk to your family members, your roommates, your friends, whoever it is that's around you the most, and say, hey, how do you know when I'm stressed? How do you know when I'm having a bad day? And have you ever had that time where you walk in and maybe your mom or your brother or your husband or wife says, "What's wrong?" And your initial response is, "Nothing, nothing, I'm fine." Our family, the people who are around us the most, they see these changes in us. It's obvious, and they want to help, and they engage us, and they ask, "What's wrong? How can I help?" But for us, because we don't recognize it, we shut them out. We don't allow them to offer that assistance that they so desperately want to provide to us. So the next time somebody says to you, "What's wrong?" or "Is everything okay?" don't just have that pre-programmed response. Stop and think. What's going on that is causing them to ask this? And maybe you answer their question with a question. If my wife says to me, "What's wrong?" maybe I'll say, "Well, I don't think anything. Why? Am I acting strange? Am I acting differently?" And I'll tell you, she nails it on the head all the time. I hurt my back one time and I was prescribed a muscle relaxer. And I remember she was hosting a garage sale and I was laid up in my recliner. Um, she walked in and I don't even remember what she said or what she did, but I snapped. And I didn't realize it. And that moodiness continued throughout the rest of the day, to the point that she got real quiet. She would avoid me. She didn't come into the same room as me. She didn't want to talk to me. And it took me a day before I realized that, holy cow, I'm really being an asshole to my wife. And she's not deserving of this at all. And I started to think, okay, what's going on? What could be causing this? Yes, my back hurts, but that shouldn't be enough for me to act this way. Well, I looked up some of the side effects, and one of the rare side effects of that muscle relaxer that I was on was irritability. So, combination of the fact that I'm stressed because my back hurts, I'm stressed because I'm worried about getting back to work, and now a potential side effect to this medication, that was really a trifecta for substantial behavior changes. And I took it out of my family. I took it out of my wife, and again, she didn't deserve that at all. So we need to be aware of how our behaviors change and understand that we will be the last ones to identify in ourselves when something is wrong. Other people will see it far in advance of us. So is this one of your brothers or sisters? Just within the last 6 months, a good friend of mine and a fellow firefighter, I've worked with him now since I started. Um, I never knew that there was anything wrong. I never knew he was depressed. I never knew anything, really. And all of a sudden, I found out one day that he was going to be putting in for leave of absence. And we were going to try to help cover his shifts. I didn't know a whole lot about why or what was going on. And eventually he came back about a month and a half later, and he sat down at the coffee table with us at work, and he opened up. And he said, "Listen, guys, I was depressed. I I didn't want to come to work. I was scared to come to work. I was using my sick days. My family life was bad." And he continued to just open up and explain to us all these things he was feeling and all these things that had gone on. And it was a combination of things that he had experienced in the military, things that he had experienced in his personal life, and some really just horrifying experiences on the job as a firefighter. And toward the end of the conversation, he said, "Yeah, I considered suicide on more than one occasion." And it really dawned on me. I felt completely incompetent at the time. That this guy is somebody that I've known for a long time. I know his family well. We're friends, um, and I never once recognized the fact that my friend, that my brother firefighter, was was hurting so bad inside that he was going to potentially kill himself. And for me, that was really a wake up call. And it's not only made me reflect more upon my own mental health and how I handle things, but also really look more objectively at my other coworkers and just really watch out for those signs and symptoms that are sometimes things that are easy to skip over. Maybe we even recognize them, but we purposely ignore those signs and symptoms because it's uncomfortable. We don't know how to respond or how to address it. So a couple different types of stress there. You see eustress, positive form of stress. It helps people work under pressure and respond effectively. Um, if we respond to a cardiac arrest, that eustress is necessary. We need our heart rate up. We need to be amped because we need the physical ability to perform CPR, to lift the patient, to effect the rescue. Same thing applies for fires. I need that eustress I don't want to be scared of fire, but I need to respect that fire is a hazard. It is a danger to me, and I need to be able to, adapt and get through the event in order to put the fire out. Distress then is that negative stress, and then that's where after the fire is over, I should be able to go back to my pre-stress state. I should go back to normal. And if I don't, that's where that distress really kind of kicks into place. After that cardiac arrest, once we've transferred care, relatively shortly thereafter, my body should come back to normal. And if it doesn't, um, that's where we need to address that. And I'll share with you guys probably well, I will tell you that it was, in fact, the worst day of my life. And I suffered from both eustress and distress, and I'd never addressed it. And looking back on it, it almost ended my career long before it ever even got a good start. I was less than a year on the job, and still as a probationary firefighter, obviously trying to prove myself, prove my worth, and just kind of keep your mouth shut, your ears open, and you keep moving forward. And that's a culture, unfortunately, that we have in the fire service that we're slowly starting to try to change. But nonetheless, that's what it was, and that's how I was handling things. And um, I remember we had a bad winter storm come in. It was snow, it was ice. We were real busy. I had been on the job exactly 11 months to the day when this occurred, and I had never worked a full arrest. And lo and behold, in inclement weather, we caught a full arrest, um, as far away as it possibly could have been from the station and still in our district. And we cover 90 square miles almost. Um, it takes almost 20 minutes to get across our district in good weather. So I don't remember exactly how long it took, but it took us a while to get out there. When we finally got there, we found an elderly male on the ground in the kitchen in cardiac arrest. We did our best. We performed CPR. We went through everything. We transported him to the hospital, but he was declared deceased shortly after we got to the hospital. And although this patient was elderly, had a substantial medical history, and I knew that weather was a factor that we couldn't control, nothing that we did was wrong. Nothing that we did caused that outcome. That outcome was predetermined. But it was still the first time I had done compressions on a real patient. Still the first time that I had dealt with stress, or I'm sorry, dealt with death rather, in the job. The first time I had dealt with family being stressed out about death. These are all firsts for me. So, anyways, I was really trying to process that. Well, because of the weather, I think we ran more than 20 calls that night, and a little after midnight, it was probably 1 o'clock in the morning, we got a phone or a 911 call for a person who had been hit by a snowplow. All the other vehicles were out, running calls, power lines that were down, vehicle accidents, you name it. So there was just three of us that were left. We jumped from an engine over to an ambulance, and we responded. Um, I got on scene. I remember getting out of the ambulance, and I kind of looked around. There was a big crowd of people on the sidewalk, and it wasn't too far from the downtown square in Woodstock. And I recognized some of the people on the sidewalk as good friends of mine that I'd grown up with. Didn't think much more of it. Went to perform the assessment on the patient, and as an EMT, I was with two paramedics, and I remember the lead paramedic that I was with. She looked at me. She said, "Help us get him into the ambulance. We gotta go." And not really understanding what was going on or why, I did. Helped get him in the ambulance. Didn't pay much attention to who the patient was or anything else. And the lead paramedic looked at me and said, "Scott, I know you've never driven the ambulance. I know you're not signed off to drive, but I need the other paramedic in the back with me. You've got to get us to the hospital as safely as you can." So I jumped up in the front seat, driving lights and sirens for the first time, driving an ambulance for the first time. The roads are covered in ice, they're covered in snow, and they're in the back doing CPR, working this traumatic arrest. So there's a lot of stress just on that alone, right? Getting to the hospital safely. There's a patient that is currently dead in the back, and the sooner we can get him to the hospital, the sooner we can maybe bring him back. So we get to the hospital safely, fortunately, and I jump out and I'm helping unload the cot, and I look down and I'm like, man, that that's a familiar face. Now, the patient was injured substantially from being hit by the snowplow, and so I wasn't able to recognize a whole lot. But we took him inside, transferred him over to the table at the hospital, and they're working him, continue to work him, and I look back, and by this time we found his wallet, and I realized that this was a great friend of mine that I grew up just about 8 houses down the street as a kid. Still hung out with him on a regular basis, definitely in the close circle of friends of mine. And I kind of subconsciously, I guess I maybe knew it or I suspected it, but obviously the confirmation hit pretty hard. And I remember just kind of standing in the back corner of the room of the trauma room, and just watching everything that's going on. Now, this is my second full arrest ever. Both of them occurred in the same night, just hours apart. And now, of course, this one is my friend. And as I was standing in the back of the room, just watching them work, um, I heard the I heard the most terrible sound that I've ever heard in my entire life. And it was the sound of a mother being told that her son was dead or wasn't going to make it. And I'll tell you what, that scream, that horrifying cry, is something that I could describe to you in immense detail still today, and that was almost 13 years ago now. And she walked into the room, and they had called it at this point. They had determined he was deceased, and there's nothing more they could do. She just collapsed on his body, hysterical. His dad walked in just about 30 seconds after that, in a similar state. And just a few minutes after that, his girlfriend walked in. And obviously, she's crying, and his mom and his girlfriend, they're both crying back and forth. And as his girlfriend reaches down to hug him, she presses on his chest a little bit. And oftentimes, when somebody passes, when the body when they stop breathing, they trap gas inside the body. And as she put pressure on his chest, it pushed some of the air out of his chest, and it sounded like he was gasping and trying to breathe. And I'll never forget her screaming at the nurse, help him, he's still alive, he's trying to breathe, and them having to try to explain to her, that he's dead, and kind of, you can't rationalize with people at that point. There is it doesn't exist. It's not possible. And I just kind of walked out of the room, and I didn't say anything to the medics that I was with. I didn't tell them that I knew who that person was. I didn't tell them it was a friend of mine. I didn't tell them how I was feeling. I put on a tough face, and just went back to doing what I was doing. And unfortunately, that involved getting a mop and mopping brain matter out of the back of the ambulance that belonged to my friend. And I was the last person in the world that should have been in the back of that ambulance cleaning up the blood and everything else that had literally, it had littered the back of the ambulance. And for a long time afterward, I thought about it daily, multiple times a day. It kept me up at night. And I just thought, hey, this is part of the job, and you just got to be tough, and you got to get past it. And that's how I dealt with it. I was tough. I didn't talk about it to people. I didn't tell people how I was feeling, and it ate me up inside for years. And it wasn't until I started teaching the EMT class, um, and I remember it was probably maybe the second or third class that I taught, and I was lecturing on this chapter, and I finally opened up and I shared the story, and boy, it felt good. It just felt good to talk about it, to say it out loud, um, and I was able to rationalize not being tough because I felt like, well, hey, I'm sharing the story for the benefit of my students, and I look back at it now, and that benefit was for me. Talking about it out loud was the best thing I could have done, and I've told every class about it every year since. Um, and I can tell you right now that had I not started talking about it, had it not become something that I was comfortable admitting that it hurt, that I was weak, um, I probably wouldn't be in this job today. So, moral of the story is, learn from my mistakes. There is no weakness. It's just vulnerability, and we're all susceptible to it. There is nobody in this world that can overcome experiences like that and not be emotionally traumatized. The important thing is that we embrace the fact that we're all human and that we work with each other to overcome these hurdles. So safety doesn't end after the incident is over, and that just means that, with scene safety, yeah, we may identify immediate threats related to the call, but the ongoing threats of the emotional trauma continues to exist. So cultural change, I'm going to kind of skip through a few of these things. Cultural change is one of the biggest life safety initiatives that we've identified, and it is something that I am proud to say is happening at a pretty good pace these days. Psychological support is absolutely imperative. And we know that it doesn't have to necessarily be from a trained psychologist, but using firefighters and other first responders and training them to become counselors is probably our best bet at this point in time. So looking at some of the thought processes that are common, we are the ones that do the helping, not the ones that need the help. Well, that's not true at all. I'll be fine. Don't worry about me. It's no big deal. I'll get over it. Thanks though. Um, these aren't coping mechanisms. We're not treating the underlying mental illness here. We're just simply ignoring the symptoms. And if you ignore the symptoms of a heart attack, the outcome may be death. If you ignore the symptoms of abdominal pain, it could be any number of ailments that cause long-term permanent disabilities. And the same thing applies for mental illness. So lifestyle changes, think about what works for you. Do what you need to do. Put a plan in place. Those self-care plans are imperative. You must have those. And you have to have the support structure at home and at work to make sure that you can implement those self-care plans and you maintain them. Following large acute stressful incidents, we can do what's called critical incident stress management, and that's where within 24 hours we sit down, we talk over the call, and just kind of get it out there. And while I don't believe that these are truly as effective as we would like them to be, I do believe that it's a good start. That critical incident stress management, we actually perform what's called a critical incident stress debriefing, and that's that meeting within 24 hours. And we all kind of sit down in a circle. We talk about the call, we talk about the incident, how we felt about it, what went well, what we would do differently, and just again, by getting it out there and discussing it, it really helps the healing process begin. So talking a little bit about death and dying. Understanding the stages and components of death and dying is important, as well as, or I should say, not just for ourselves, but also to understand how family is going to react to these types of situations. And at the end of the day, most people they aren't exposed to death except for at funeral homes, and it's a controlled environment, and all the yes emotions are high at a funeral home. The body is prepared appropriately. Sometimes it's not even an open casket. For us, we see the raw experience, the raw form. We see the body in terrible positions, terrible circumstances, and for us, that death is much different than it is for many others. I could give you, I can't even begin to tell you how many experiences that are just different. People hit by a train, people who died and nobody knew, partially decomposed. We talked about the stillbirth earlier. So many experiences, and it's entirely different than what the vast majority of the world will ever see or deal with. So understanding reactions to death and dying. The emotional stages: the denial, anger, bargaining, depression, acceptance. You need to know those 5 stages in that order. And everybody goes through these. Everybody. What's different is that some people go through them quickly. Some people could go through these in hours or a couple days. Others may take weeks, while some take months or even years. And each stage lasts a different period of time, and again, depending on the situation, the individual, and a few other factors. But it's going to happen. And I've seen these stages happen on many full arrests that we've gone to, where a spouse, let's say a 75-year-old male, is in cardiac arrest, and we're working on the patient there at the house, and his wife is there, and she's obviously upset. first and foremost, in regards to that, we keep the patient, or the family rather, in the room. We allow the family to be in the room to watch what we're doing. We assign a liaison to the family member so that we can kind of explain what's going on and be there as a support mechanism. But it has been found that people are able, they have more closure. They're able to cope much better if they are able to witness all the efforts that go into trying to save their loved one. And it helps to kind of process a little bit better. But anyway, the denial phase, I can't tell you how many husbands and wives have, broken down crying and, no, it can't be my husband. It's not him. It's not his time yet. Please don't let him die. This can't be happening. And, that denial stage happens pretty quickly. Um, from time to time, anger will kick in, and this is something that we have to be really delicate with. It's not uncommon for a family member to direct their anger at us. Why aren't you doing more? Why aren't you transporting him? Why aren't you, doing this? And, it's your fault. You took so long to get here. If you would have gotten here faster, he'd be okay now. And we have to understand that in that situation, they're not in their right state of mind. They don't understand what they're saying, who they're saying it to. It is just a pure emotional response. And it's tough, but we have to embrace it. We can't become defensive. We can't argue back. There's nothing that we're going to say or do to prove them wrong at the time. Um, you know, Unfortunately, it's our job. We're going to take that verbal beating. If they want to yell at us, if they want to blame us and pin it on us, we're just going to take it. We're not going to argue. We're not going to fight back. Um, Obviously, if it becomes a physical aggression where they are potentially going to cause physical harm to us, no, we don't have to, stand there and be a punching bag. We can take action to protect ourselves, but generally speaking, yeah, we're going to be an emotional punching bag at a minimum. Bargaining. A lot of times we'll see this bargaining phase with people who are uh, um, diagnosed. Couldn't think of the word. Diagnosed with a terminal illness, cancer, for instance. Dear sir or madam, you have 3 months to live. And they'll go through that denial stage, they'll go through that anger stage, and then they'll go through the bargaining. Okay, but first let me, check these items off my bucket list. First, let me get my life insurance in order. First, let me help, start preparing my funeral, those types of things. And then over time, they'll go through a depression phase. And I think we all kind of have an idea of what that depression phase may look like. And eventually, they'll get to acceptance. And uh, that acceptance phase is sometimes misrepresented too. Acceptance, for a terminally ill patient may be okay. I've come to grips with the situation. I understand that it's outside of my control. um, I just want to live out my last days the best I can with the people I love, and it is what it is. But that acceptance phase also can be alarming in the instances of suicide. Um, People who are hurting inside emotionally and are thinking about suicide, they may show signs of depression and with being withdrawn and all these signs and symptoms that we kind of mentioned earlier. And then all of a sudden one day they seem fine. They show up and they've got a smile on their face and they're laughing and joking and everything's just great. Like, wow, this is awesome. I haven't seen this person feel so good in such a long time. I'm really excited. When in fact what it is they finally accepted, hey, you know what? Suicide is the answer. That's what I'm going to do. And that acceptance phase allows them to kind of, it's a weight off their shoulders, and then they just do it. So that person that said, that we say, well, they seemed fine. They were laughing just this morning. They were doing this. It's because they had reached that acceptance phase, and we had either missed or chosen to ignore all of those early signs and symptoms. Depression doesn't just clear up like that. It's something that takes time and requires therapy and talking about it and stuff like that. Recognizing the patient's needs and listening empathetically. Let's first real quick talk about the difference between sympathy and empathy. So sympathy means that, yeah, we feel bad for somebody, the experience that they're going through. Boy, that's got to be terrible. I don't know how they feel. I don't know what it's like to be in their shoes, but I can only imagine that just really sucks. That's sympathy. Empathy, though, is when we can relate. We can feel what they feel. As a parent, when a child is ill or injured, I can be empathetic with that parent because I've had a child that's ill. I've had a child that's injured. And I have an idea of how they feel because I know how I felt. But somebody who isn't a parent, it would be tough for them to be empathetic. Dealing with somebody that has a substance abuse issue. If I haven't personally dealt with substance abuse with a friend or family member, I wouldn't be able to be empathetic of other family members that are dealing with this. So empathy, when it says here, listen empathetically, at a minimum, we want to listen sympathetically, but we're not here to just feel sorry for people. We're here to interject emotion and compassion, and for these people to understand that we genuinely care about them and we want them to feel better. We want to help them, and by portraying those things, that's where we really get that empathetic response. Do not falsely reassure. We never lie ever, and that includes falsely reassuring people. If they say, "Am I going to die?" Don't say no. Never say, no, you're not going to die. Don't think like that. Don't talk like that. Maybe the response is, hey, we're going to do everything we can to take care of you. I can promise you we're going to give you the best care possible. Because those things are, that stuff you can promise. You can control that. But you may not be able to control whether or not they live or die. So never, ever make a promise or an assurance that is outside of your control. And a lot of times, the best thing you can do is shut up and listen. And if you come work with me at the firehouse, I'll tell you day one, God gave you 2 ears and 1 mouth. That means you should listen twice as much as you talk. And when it comes to these situations, that is the honest to God truth. You need to just be ready to listen to people. And sometimes the best response is no response at all. And if it's outside of something that you can do, where you're comfortable helping, refer them out. There are countless resources available to your coworkers, to your family members, to your friends. Refer them out to some of those resources. We're going to watch a short video here that talks about empathy and talks about how we need to be better at listening rather than responding.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you can climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, No. You want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with "at least." Yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, "I don't even know what to say right now. I'm just so glad you told me." Because the truth is, rarely can a response make something better. What makes something better is connection.
So what do you think about that? Rarely can a response make something better. How many times have you said "at least"? How many times have you put that silver lining on things? I know I've done it more times than I could ever count. And the important thing is, now I understand that I just need to be a better listener. Listening is the best answer sometimes, not coming up with a response to try to make them feel better. Because in reality, sometimes nothing you say is going to change things. So in the fire service, we use emergency traffic over the radio to signify that, hey, we have something really important to say and everybody needs to shut up and listen. And if we begin to recognize that there are some warning signs of mental health issues in a friend or a coworker or family member, we need to call out that emergency traffic. And we need to make sure that we address the issue long before it ever gets to a mayday situation where somebody is lost or even worse, deceased. All right, talking a little bit about scene safety here. EMS, I'm going to respectfully disagree with this slide. EMS is not usually a dangerous profession. In fact, what we're starting to see these days is a lot of danger associated with EMS. And we see, going back to Columbine, for instance, 1999, those two gentlemen put bombs inside of vehicles in the parking lot at Columbine High School. Those bombs were meant for the first responders. And fortunately, they used some cheap watches, some cheap time devices, and they never went off. But we are becoming targeted these days. Just recently in Wisconsin, a paramedic who was on the scene of just a routine evaluation was shot and killed. And it was a call that I would say we go on 15 times a week on a regular basis in Woodstock. And there was no significant red flags. But sometimes those warning signs aren't as obvious as we want them to be. And we can only learn from what's happened in the past and try to prevent it from reoccurring. So let's take a quick look at that video from Appleton, Wisconsin, and see, what warning signs do you see? What are some things that we could maybe pick up on to make sure that this doesn't happen again in the future?
Just go to the hospital, get checked out. If they say you're okay, then you're on your way. I don't want you to get home though, man. You'll get home. Listen, I talked to my boss. The only other alternative to you not going voluntary, if you go voluntary, you hop on the cot, you ride down there, you get checked out, it's done. If you don't go voluntarily, here's what I have to do. I feel that you're not making a safe choice in your best interest. I'm consciously talking. You're not making a safe choice in your best interest, and I have to involve crisis. We have to go to the hospital anyway to start that process, and we have to have them evaluate to make sure that you're making safe decisions for yourself. I don't want to go there.
Real quick, do you have any weapons on you?
No, sir.
Okay. You kind of have a bulge on your right side.
That's my phone.
Okay, don't reach for anything. Just kind of
That's my phone.
Hold on.
I don't want. Look, man, I have a problem with officers touching me.
Lift up your shirt then.
Sure.
I get
Just lift up your shirt, bud. Lift up your shirt. We want to make sure everybody's safe.
Look. Look.
Shots fired! Shots fired! Shots fired! Don't move! Don't move!
Okay, so typical situation there, something we run across all the time. That gentleman was unresponsive on the bus. Sorry about that, little YouTube in the background there. Anyways, the gentleman was unresponsive on the bus. They administered Narcan as a result of a narcotic overdose. And what you saw there was a product of him awake and talking after he had received the Narcan. And he was irritable, upset, didn't want to be very cooperative. And the police officers were doing exactly what they were supposed to do. And they identified the potential of a weapon. And unfortunately, they're limited in whether or not they can go hands-on with an individual. So in this situation, that person backed up, was able to draw his weapon relatively quickly, and opened fire. And the result was one officer injured and one firefighter that was killed. So scene safety is not something that we assess once. It's ongoing. It's nonstop. We're always trying to survey the scene to look for any potential changes. Hazmat incidents are one of the kind of the hidden hazards when we're doing scene safety. A lot of times those chemicals aren't readily obvious to us. You think about something like carbon monoxide, odorless, colorless, tasteless, and extremely deadly. So we have to look for outside warning signs. Maybe we carry monitors with us, but maybe we have to look for basic signs and symptoms of how people are acting, being aware of the environment. Is the potential for CO there? There's a whole bunch of things. And hazardous material, you will receive more hours than you can possibly count in hazmat type training in the future. So a good way of determining if you're too close to a hazmat situation is a rule of thumb. If you can put your thumb in front of you and still see the scene, you're too close. So obviously that's an exaggeration, but what we want to do is make sure that we're staying plenty far away from the hazmat scene and allowing the trained hazmat professionals to mitigate the situation. So your role as an EMT, recognize that there's potentially a problem, take immediate action to protect yourself, your partner, your patient, and bystanders, and then notify the trained individuals, specifically the hazmat team, to come and mitigate the situation. We should not be mitigating hazardous material events. Terrorist incidents. I'm going to do a terrorist presentation later on in the semester, so I'm not going to get into this a whole lot right now, but the Department of Homeland Security has the see something, say something motto, meaning that if you observe any type of behavior that is odd or concerning to you, you should preemptively report it. It's better to report something that turns out to be nothing than to ignore a potential indication of a terrorist attack and allow that attack to be executed because we did not report it preemptively. Rescue operations. We will again have specialized training in vehicle extrication or specialized rescue, high-angle rescue, confined space rescue, those types of things. So when we identify that something is outside of our scope of training, something that we are not properly equipped to handle, we should take a step back, call for the appropriate resources, and allow them to mitigate it. If we try to get ourselves into precarious situations, the higher risk there is that we're going to create additional victims for everybody else to have to rescue down the road. So a great example of a law enforcement officer standing way back using binoculars to observe a placard and to observe if there is a hazardous situation there. Violence, we always want to carry portable radios with us. In our system, all the dispatch agencies that are used within Mavis Division 5 or within McHenry County have a code phrase that is a distress call. So if I get on the radio and we use NERCOM as our dispatch center, we call them McHenry, that's how we address them on the radio. If I got on the radio and said McHenry from Woodstock 481, be advised we are on location treating an advanced life support patient. If I say advanced life support, not ALS, but if I say it outright, advanced life support patient, that is the distress call. And their protocol at that point is to send everybody to wherever my last known location is, and I'm going to get a lot of help. And that's all I have to say. But obviously I need to have my radio with me in order to communicate that. Here you'll see that as they knock, they are standing off to the side, not in front of the door. Some of you may remember Deputy Manis, who was shot and subsequently died about a year later from his injuries out in Holiday Hills. And what had happened is they approached a house for a possible domestic disturbance. They knocked on the door, and the individual on the inside opened fire on them with a rifle through the door. So those rifle rounds came right through the door and impacted them. We need to be aware of everything. And standing back and knocking from the side like this is exactly what we should be doing in all circumstances. Other things with violence, surveying the scene, consider lights and sirens. If you're going for, police are on scene requesting an evaluation, coming in hot may not necessarily help the situation. It may get the patient riled up or upset. If they don't know that you're coming, mom calls 911 and says that her 16-year-old daughter is locked in her bedroom, threatening to harm herself. And all of a sudden she starts to hear sirens and sees lights outside and everything else. That may instigate her to do something rash or do something that she wasn't otherwise planning to do. So sometimes we need to be somewhat stealthy as we approach the scenes. Always have your head on a swivel. 360-degree situational awareness. Keep an eye out for all types of different hazards. With pets, we think of, okay, a dog bite or dog attacking us, and sure, that's something we need to watch for. But also think about, look at the dog, and if the dog is docile, doesn't get up, doesn't acknowledge you, doesn't bark at you, could that be a warning sign of something else? Could that be a warning sign of carbon monoxide in the house? Who here has a dog that won't at least bark or wag its tail or get up and acknowledge a stranger as they walk in the door? So if you see a dog acting oddly calm, that could be an indication of some type of environmental hazard within the home. The 3 R's: retreat, radio, and reevaluate. So always retreat to an area of refuge, somewhere that you can take cover and be safe. Radio in the hazard. Be explicit in the help that you need and what's going on. And then reevaluate whether or not you want to actually enter the scene. All right. So here's an example. And again, if you identify that the scene is unsecure for whatever reason, retreat back and allow law enforcement to come in and secure the scene for you. So that is the end of Chapter 2. I hope that you guys took something away from it. Just to quickly summarize, the big take-homes should be the importance of protecting yourself in a way that allows you to provide a higher quality of care to your patients and also to that of your partner. We do that through good self-care plans that include exercise and diet, appropriate stress relieving techniques. We also need to identify the presence of stress within ourselves and engage our family members and loved ones to help us identify when we may be feeling stressed and we may not know it. We need to embrace mental health as something that is not a weakness, but rather something that affects all of us, and we need to begin to mitigate it. We need to accept it. We need to be comfortable talking about it. We need to identify the signs and symptoms in others, and we cannot be afraid to approach them, or at a minimum, reach out to somebody that is comfortable approaching them. Simply ignoring it or blowing it off is the worst possible thing that we could do. We need to evaluate the scene. It's an ongoing evaluation. It happens constantly from the time that the tones drop until we transfer patient care. And we need to be aware of a scene that could potentially change at any given moment in time. And I think those are the big things for Chapter 2. I hope you guys enjoyed it. And if you have any questions, you'll reach out to me or any of your other instructors.